All right, hi, this is Scott Peters. Today's session is entitled Medical Marijuana and Brain Injury, Where We've Been, Where Are We Now, Where Are We Heading? Just to give a little context, I work for a post-acute brain injury program called REMED, and I've been at REMED for over 30 years now. And a big part of the work that I've done with REMED is in the area of substance abuse programming for TBI survivors. And so I will say for the majority of my career, marijuana use and brain injury is something that I advocated against. I remember back in the 1990s working hard to pull together good information about the negative impact of marijuana use on TBI survivors so that I could provide them with good evidence-based information. However, my thoughts began to shift as the REMED program has been working with folks with chronic pain who come to us, potentially having abused narcotic pain agents and specifically opiates. So I attended a presentation a few years back about the potential benefits of cannabidiol, CBD, in working with chronic pain populations. And it intrigued me. And so I began to take a look at medical marijuana and specifically CBD. So the presentation today is what I found out. Again, my primary motivation was to be able to say, can I and can REMED think about medical marijuana differently than the way we've been thinking about it over the past number of years regarding substance abuse. So my intent, excuse me, today is to provide you with current information about medical marijuana. Hopefully it's a review to you, but it's also, really trying to take a look critically at what's out there so that we can then discuss the steps we may want to or need to consider to incorporate medical marijuana into your practice in New Jersey, my practice in Pennsylvania. So that's the purpose behind this, is to share information. So let's start by talking about how prevalent is cannabis use in the United States. It's quite prevalent. Greater than 100 million adult Americans report marijuana use now. The prevalence of cannabis use peaked in the late 1970s when more than 1/3 of high school seniors and 1 in 8 Americans over 12 reported past month use. That was pretty significant. The data suggests that there was a reduction in the 80s and 90s, but then a rapid increase that has essentially remained where it's at. But then since 2007, there's been a steady year-over-year increase rising from 5.8% to 8.4% increase in 2014, which represents about a 45% increase. So clearly, it continues to be used at a fairly frequent level. 2015, there's been an estimated 22.2 million of more than 265 million Americans aged 12 and older reported having used cannabis in the past month. The statistics show us that primary use of cannabis in the United States continues to be recreational, almost 90%, with only 10.5% for solely medicinal purposes and about 36.1% for mixed medical and recreational use. And there are greater than 2.3 million legal medical marijuana patients now registered in the United States. And this statistic is probably about a year old, so I'm sure there's much more than that. But the statistic that I was able to pull from the New Jersey website around medical marijuana is that over 51,000 patients, 2,000 caregivers, and now 1,000 docs are participating in New Jersey's medical marijuana program. So cannabis use is pretty prevalent. But what about in rehab? So that's an area that We suspect there's more cannabis use than what we thought, but there was an interesting article that I chose to present to you in this presentation. That was a 2018 study published in the archives of PM&R entitled Cannabis Use in Individuals with Spinal Cord Injury or Moderate to Severe Brain Injury in Colorado. So it's important to recognize that Colorado is one of the states where medical cannabis has been legal since 2000 and recreational use was legalized in 2012. So they have people that are in their clinics that have a fairly easy access to cannabis. And so the team that put together this study, which was, by the way, founded or funded by a grant from the Craig Hospital Foundation. Craig Rehab, as you know, is a center of excellence in the Denver area. So this team put together this plan, and they looked specifically at spinal cord injury and brain injury because of the chronic symptoms of pain, insomnia, spasticity, and mood disorders that both of these populations typically will display. So what they did was they put together a survey of 51 individuals with spinal cord injury and 65 individuals with moderate to severe brain injury that were currently involved in their program, taking part in model systems programming at Craig Hospital. They asked some very specific questions, and the questions that they asked included, number one, did you ever use cannabis prior to injury? And have you used cannabis since your injury, yes or no? Since your injury, have you used cannabis for any of the following reasons? And then they listed things like pain, sleep, and so on to try to get a sense of the purpose behind it. Since your injury, which of these methods have you used? And they asked to list or select from a list that was given from inhalation to edibles to topicals and so on. Next question was, how often would you say you use cannabis, daily or less than daily? And then have you experienced any negative side effects from your use of cannabis? So these were the kind of questions that the survey probed. The summary of the results of this survey was that about 70% reported use prior to injury and a bit of a decline, 50% since injury. And you can see that the use declined in spinal cord injury by 22%, 32% in brain injury. A high percentage they found in both groups endorsed recreational cannabis use. The spinal cord injured population all listed a number of medicinal reasons, including spasticity, pain, and sleep, as well as anxiety, whereas the TBI group didn't endorse as many medicinal reasons for use. After recreational, they talked about reducing anxiety, improving sleep, and generally other reasons like mellowing out. So this is one study that just talks about the experience of this treatment team at Craig Rehab, but it could be representative, especially as New Jersey is looking to potentially be one of the next states to legalize recreational marijuana based on the upcoming elections. So I think we all have to be prepared as though, you know, people could be coming to our clinics, both inpatient and outpatient, with a desire to incorporate marijuana into their plan. So we're going to be in a position of having to respond to that. So this is kind of an obligatory slide, meaning that every medical marijuana presentation I've gone to has wanted to, you know, talk about this idea that cannabis has been around for a long time, and specifically used as a medicine for a long time. The one statistic, it's been in use, first recorded in 5,000 years ago when the Chinese used it to treat malaria, constipation, rheumatic pain, and as an analgesic in childbirth. 1839, European physicians were published using cannabis as a muscle relaxant, an anticonvulsant, antiemetic, um, and analgesic properties. US um, listed it in the US dispensatory in 1845, but things then began to change in the 1900s. In 1906, Congress passed the Pure Food and Drug Act. And this is the first time that cannabis was regulated as a drug. In 1910, Congress listed cannabis as a narcotic and also regulated it as a poisonous substance. The 1930s, the Federal Bureau of Narcotics was formed, and there was this even increased scrutiny of cannabis use. The head of the agency was a fellow by the name of Harry Anslinger, and I mention him because there's some iconic images out there of movie posters and movies that were entitled Reefer Madness. This idea of, demonizing the use of marijuana, and what they thought did Mr. Anslinger use this kind of against people of color that were deemed undesirable. So, who knows kind of what all went along with that, but Federal Bureau of Narcotics took a close look at marijuana use. 1937, the Marijuana Tax Act. And marijuana, by the way, is spelled the way they spelled it back then, with an H versus a J, and made the possession and transfer of cannabis illegal. In 1938, the Pure Food and Drug and Cosmetics Act was enacted, which then went on to become the Food and Drug Administration, and it was still listed by the FDA as a dangerous drug. 1940s saw a little bit of a reduction in the use of hemp because of the war and cultivating use of nylon to replace hemp as an essential fiber material. Then in the 1950s, Congress instituted severe mandatory sentences for a variety of drugs, including cannabis. I find this amazing that the penalty for cannabis possession in 1956 was minimum of 2 to 10 years in prison and a $20,000 fine. Not much going on in the 60s. Peace, love, war, all that kind of stuff was happening back then, but no additional anti-drug legislation. But then kind of a key feature happened in the early 1970s under the Nixon administration. They went to war on drugs, beginning with something that I'm sure you're familiar with, which is the Controlled Substances Act, that created the scheduled list of drugs, which still is active today. So this is the Comprehensive Drug Abuse Prevention and Control Act of 1970. And again, it's still in play today, where medications or drugs are listed under specific schedules, and the schedules range from a Schedule 1 to Schedule 5 controlled drugs and medication. So the idea is that a Schedule 1 drug is a drug that is deemed to be highly addictive. There's a high potential for abuse, and there's no acceptable medicinal use. So these medications, or these drugs, are illegal. And these include heroin, LSD, ecstasy, and marijuana is included in there as well, peyote, quaaludes, and so on. But marijuana was placed in the Schedule 1 category in 1970 and has remained there since that time, which is why marijuana remains at a federal level illegal. Schedule 2 has the exact same definition or of characteristics as Schedule 1, that it's highly addictive, there's a high potential for abuse, but you have an acceptable medicinal use this time. And so this is where the narcotic pain agents come in. And they include hydromorphone, methadone, oxycodone, morphine, opium, codeine, all fall into this Schedule 2 definition. So again, the key difference between Schedule 1 and Schedule 2 is the acceptable medicinal use of those agents. Schedule 3 agents are defined as having a moderate to low risk for dependence. There's less of a risk for abuse. And this is where you find agents like Tylenol with codeine, the medication that you frequently find in medication-assisted substance abuse programs like Suboxone fits under the Schedule 3 classification. A Schedule 4 medication has a lower potential for abuse relative to Schedule 3. Interestingly, I find interestingly that the benzodiazepines fit into this Schedule 4 classification. So drugs such as Xanax, Klonopin, Valium, Ativan, Restoril, Halcion are considered a Schedule 4 controlled substance. And then the Schedule 5 controlled substances are defined as having a low potential for abuse. Preparations contain limited quantities of certain narcotics like Robitussin AC that has phenogram and codeine in it and so on. So this, again, is the key feature which continues to keep marijuana illegal at a federal level, which is what influences the ability to access marijuana for research purposes. And so this illegality feature at a federal level continues to have a strong influence on accessing medical marijuana. So continuing on beyond 1970, we've got the 1980s, where criminal penalties under the Reagan administration became much harsher. Minimum sentences, the 3 strikes rule. For those of us who are old enough to remember Nancy Reagan saying, "Just say no," and that iconic commercial on TV of "This is your brain on drugs," and it shows a frying egg. So there was a real strong push against drugs at that time, and including marijuana. In the 1990s, however, things began to change. California Proposition 215 passed in 1996, legalizing medical cannabis. Currently, 33 states have some form of medical and/or recreational use protections for cannabis. So this has been growing kind of year after year. 33 is the current. New Jersey first adopted the Medical Marijuana Act in 2010 and operationalized it in December 2012. In 2019, New Jersey's Governor Phil Murphy signed the Jake Honig Compassionate Use Medical Cannabis Act. And so that's an important act that some of the changes are helping to make medical marijuana more available to people. So for example, the Jake Honig Compassionate Use Medical Cannabis Act allows now a monthly limit from 2 ounces to 3 ounces of medical marijuana. It extends the authorization period from 90 days to 1 year as certified by a qualified physician. It now allows edible medical marijuana to be available for adults in addition to minors. There's a plan to phase out sales tax. Key thing here is it expanded to allow physicians' assistants and advanced practice nurses to authorize medical marijuana versus just physicians. So greater access to additional healthcare providers to help you get into the medical marijuana program. There's employment action protections for patients. You now can have up to 2 caregivers designated to help you to access medical marijuana. Home delivery is approved. So all of these, as I understand, were approved to be able to help make it a little easier for the populations that are approved in New Jersey to be able to access medical marijuana. And then, as previously mentioned, New Jersey is going to place a marijuana referendum on the 2020 ballot in, as I understand it, in November 2020 to be able to determine whether marijuana can become recreationally legalized in New Jersey. So things are definitely moving. Okay. And so this is just kind of a map that gives you a visual representation of what I had indicated, that the idea that there are 33 states now, including, that also includes the District of Columbia, Guam, Puerto Rico, and the US Virgin Islands have approved comprehensive medical marijuana programs. 12 states allow the use of low THC and high CBD. So we'll talk a little bit about that later for limited medicinal purposes. And 3 states, specifically Idaho, South Dakota, and Nebraska, remain in which there is no form of cannabis, including CBD, that's legal. And this information comes from a resource called the State Marijuana Laws from 2019. Okay. So shifting from kind of how prevalent it is and where it's come from to what the FDA has licensed up to this point, even though it continues to be illegal, marijuana is illegal at the federal level. There are 3 drugs that the FDA has licensed that are based on cannabinoids. The first one that a lot of people have kind of heard about is dronabinol. Goes by the trade name Marinol. And it's a synthetic, so it's a lab-made delta-9 THC, which is marketed under the name Marinol, and it was associated with, or it was initially designed to help combat nausea and vomiting associated with chemotherapy and to stimulate appetite in AIDS patients due to wasting syndrome. I see it periodically come through our program if somebody is really struggling with appetite suppression, that Marinol can be prescribed, and it's considered an FDA approved drug. Another drug that is FDA approved is called Nabilone. It too is a synthetic analog of delta-9 THC, which is THC. It's and which we'll talk about the difference between THC and CBD in a bit. And it's used in the same manner, this idea of combating nausea and vomiting as well as an appetite stimulant. So it's the same as dronabinol. And then a little more recently is an agent called Epidiolex. So this is a new drug, and that is concentrated CBD oil, 98% CBD, which is cannabidiol. And again, we're going to talk about the differences between THC and CBD. But it was developed as an anti-seizure drug for Dravet and Lennox-Gastaut syndromes back in 2013. Dravet syndrome is a severe seizure disorder. Lennox-Gastaut syndrome is another severe seizure disorder in childhood. So when other anticonvulsants aren't working, to be able to turn to Epidiolex is what it was designed for. It's important to recognize, well, first of all, let me say that dronabinol and Nabilone, from a standpoint of scheduling, dronabinol is a Schedule 3 medication according to the schedule that was previously reviewed, whereas Nabilone is a Schedule 2. I'm not sure the reason why Nabilone got a 2 and dronabinol got a 3. But Epidiolex came in as a level 5 agent. So the CBD came in as a level 5 agent. And most recently, this is as of April 6, 2020, the DEA no longer considers Epidiolex a controlled substance under the Federal Controlled Substance Act. So it is no longer under that schedule. So what that means is Epidiolex can also be used for off-label purposes. For those reasons, we're hoping to see that the price of this drug does reduce. Now, one other medication that is currently not approved by the FDA, but it is been actively approved by a number of countries, 15 countries outside of the United States. But you see it a lot in the research and in the literature studies. It's a medication called nabiximols. The trade name is Sativex. It's an ethanol cannabis extract that's composed of THC, the delta-9 THC, and CBD in a 1-to-1 ratio. So the same amount of both of those. It comes in an oral mucosal spray, and it's used for symptomatic relief of MS and an adjunctive analgesic treatment in cancer. So like I said, launched in 15 countries, been around for a while, first approved in the UK in 2010. Ultimately, we hope it comes here at some point because it seems like it's a pretty effective medication. Okay. So let's talk about how cannabis works. Come to find, in the 1990s, there was the discovery of 2 cannabinoid receptors in our bodies. So there are literally receptors that respond to cannabis. And so they are CB1 and CB2, cannabinoid 1, cannabinoid 2 receptors. CB1 receptors are located primarily throughout the central nervous system and to a lesser extent in the peripheral tissues. CB1 receptors are spread throughout the brain and are found in high densities in neuron terminals of the basal ganglia, the cerebellum, the hippocampus, neocortex, hypothalamus, and the limbic cortex. There are very few CB1 receptors that are found in the brainstem. And this is one of the reasons why cannabinoids are safe, that they don't affect us at the brainstem level. CB2 receptors are present mainly on immune cells and peripheral tissues, and they typically are associated with anti-inflammatory features, immunosuppression, and anti-nociceptive types of activities. They're found predominantly in areas like the spleen, the tonsils, and the thymus. But I think it's pretty cool that our bodies are built to be able to, respond to cannabinoids. So what are cannabinoids? Depending on what you read, the number may be a little bit different, but the bottom line is that there's a lot of cannabinoids in the marijuana plant. There's more than 104 different cannabinoids, which are defined as the group of psychoactive chemical compounds found in the cannabis plant, as well as other compounds in the cannabis plant, like they're called terpenoids, which are organic compounds responsible for aroma and taste. Flavonoids, which are antioxidants that are found in many plants, and nitrogenous compounds, which are things like amino acids. So it's a very complex plant. The most prevalent cannabinoid is delta-9 tetrahydrocannabinol, or THC. So that's the last time I'm going to say that whole name, but THC is what we're talking about. And it's a partial agonist for CB1 receptors. And this is the cannabinoid that is psychoactive. This is the agent that gets you high when you ingest it. Cannabidiol, or CBD, is the most abundant cannabinoid in hemp. It's not psychoactive, and it's been found to, or it's been perceived to negatively modulate CB1. So kind of has this effect on the CB1 receptors of modulating them in a negative way. Also known as a agonist of serotonin 5-HT1A receptors, and therefore it's implicated, and this is where the implications come in, about symptom relief of various neurological disorders, including anxiety, seizure, and movement disorders. So they're the two cannabinoids that we talk mostly about. THC, which has the psychoactive properties, and CBD, which is also quite abundant. It's implicated in being able to treat various conditions, but it doesn't get you high. All right. So some of the studies that we talk about a little bit further are going to talk about, whether they were using THC, CBD, or both. And by the way, medical marijuana includes both THC and CBD. But it's also important to recognize that we also produce our own cannabinoids in our brain. They're called the endocannabinoids. And the endocannabinoids, were important as trying to keep our body in some level of homeostasis. The two primary that have been identified are called 2AG. I'm not going to try to pronounce the full title of 2AG, but it's specifically been identified during neuronal development and for synaptic communication between neurons, brain development, and inflammation management. And then there's another endocannabinoid called anandamide. And so you can see what that has to do. So the bottom line is we have endocannabinoids that we produce. We have synthetic cannabinoids, like a couple of the medications that I talked about are synthetic, like dronabinol and nabilone. And then if you hear the term phytocannabinoids, PHYTO cannabinoids, these are the compounds that are found in plants. And research is going on about all of them. How much of the cannabinoid, what percentage of amount of type is going to be most effective in treating various conditions. So those are the cannabinoids. And so then when we talk about cannabis-derived products, there are different routes of administration that have an impact. So the products that we typically see in medical marijuana protocols include cannabis buds, which are the dried cannabis flowers, cannabis resin, like hashish and bubble hash, and then there's also cannabis oil. And you can see some of the terms that are used for cannabis oil and the percentage of THC found there. The routes of administration is that cannabis can be smoked. It can be inhaled through vaping, oral, eating of or sprinkling that is ingested orally. And then there's also topicals that are absorbed through the skin and mucosal tissues, creams, patches, vaginal sprays, rectal suppositories, oral mucosal sprays, and so on. So different products, different routes of administration to be aware of. And so the route of administration, or the route of administration, does have an impact on how quickly you see the effects of this ingestion. Inhalation is determined to be the quickest way through smoking, vaping. Here, the THC quickly diffuses to the brain as the perceived high is experienced in seconds to minutes. Blood levels reach maximum about after 15 to 30 minutes, then rapidly subside within 1 to 3.5 hours of duration. So, quick onset, time-limited duration. Dabbing, which is a term for flash vaping butane hash oil, Base concentrates are different and stronger intoxicating effect than even smoking and regular vaping. Oral edibles like bakery products like cookies and fudge and stuff like that, ingested in juice and teas, oils, capsules, and so on, doesn't produce the effect for about 30 minutes to 2 hours. The high lasts for about 5 to 8 hours, so a little slower onset. Topicals, it would be variable for the effect, and it's only specifically localized. And then the oral mucosal sprays, a maximum effect in 15 to 45 minutes with a 6 to 8 hour duration. And we'll talk about kind of how important this is as it relates to, projecting somebody coming into, your clinic in rehabilitation, and when did they last ingest their medical marijuana, and what you do about that potentially. Okay, so again, when I first heard about medical marijuana and I had a bias against THC, I was concerned based on all those years of looking at the negative impact of THC. This idea of CBD or cannabidiol sounded almost too good to be true. Again, I was looking at alternatives to narcotic pain agents, looking at what the literature says about this, and begin to see about the neuroprotective elements of CBD, where they talked about CBD's role in anticonvulsant effects, neuroprotective, anti-inflammatory effects, analgesia, anti-tumor, anti-anxiety, antipsychotic, that it was not psychoactive, there's no receptors in the brainstem. All of these things said, my God, why wouldn't we use CBD? And so that's what really got me to take a look at the literature to see what's the literature saying. So what we know is that there's not great research that's out there. There's a lot written, but there's not great research. And I kind of, through my reading, began to see a reference that kept popping up. And the reference was this. It's from the National Academy of Science, Engineering, and Medicine. It was produced in 2017, and it's entitled "The Health Effects of Cannabis and Cannabinoids, the Current State of Evidence and Recommendations for Research, 2017. People continued to say that this was the most comprehensive review of the literature. And so I dug into it. And by the way, this document is available to you on the website of the National Academy of Science, Engineering, and Medicine. It's free. It's about 400 pages. You can get a printed manuscript for a nominal fee. It's dense, but it's really good. So the bottom line, just to talk a little bit about how they did this report, because we're going to review some of the results of this report. I felt like it was the most sound information that was out there. I've since looked at a couple of additional articles that were written in 2018, 2019, and they continue to reference limited studies and so on. So this felt to me to be the most comprehensive, and therefore a resource that you should be familiar with. So in March 2016, the Health and Medicine Division of the National Academies of Science, Engineering, and Medicine put together an ad hoc committee of experts to develop an in-depth review of existing evidence regarding the health effects of using marijuana. At that time, and still are, no acceptable standards exist to help guide individuals as they make choices, but it's available. And so, people are acting on the availability and what they think they know. So this ad hoc committee, which was comprised of experts in the field of marijuana, addiction, oncology, cardiology, neurodevelopment, immunology, toxicology, among others, were pulled together to take a look at what does the research tell us. Where's the evidence about the impact of cannabinoids on certain conditions, and does it cause certain conditions? So what they did was they conducted a comprehensive review of the evidence using acceptable approaches of literature search, evidence review, grading, and synthesis. Now, the government has done this on a couple of other occasions. In 1982, the Institute of Medicine developed a report entitled Marijuana and Health. In 1999, the Institute of Medicine developed a report entitled Marijuana and Medicine, Assessing the Science Base. So this is the most recent governmental sponsored look at marijuana, but it's been done over the last 30 years, starting in 1982. So the bottom line is that the committee conducted an extensive search of relevant databases and initially were able to retrieve more than 24,000 abstracts. In the end, the committee considered more than 10,700. What they did was they developed an approach that resulted in looking at only recently published systematic reviews since 2011 and high quality primary research. And so they looked at the literature and they applied weight of evidence. And the weight of evidence that I want to walk through, because it's going to be referenced when I talk about the different outcomes that they found with recommendations. So it could be conclusive evidence has been found, where there's strong evidence looking at randomized controlled trials to support the conclusions and supportive findings from good quality studies. So that's kind of a quick and dirty discussion of if something is deemed to have conclusive evidence. Substantial evidence is that there's strong evidence to support the conclusions or associations between cannabis and cannabinoid and health points of interest, and that it's good quality studies, few or no credible opposing findings. Next is moderate evidence, and this is that there's some evidence to support the conclusions. Fair quality studies, very few or no credible opposing findings. Next category is limited evidence, which is defined as having weak evidence to support the conclusion. A conclusion could be made, but there is significant uncertainty to chance, bias, or other confounding factors. And then lastly, that there's no or insufficient evidence. And this is defined as saying that there's no or insufficient evidence to support the conclusion. No conclusion can be made because of substantial uncertainty due to chance, bias, or confounding factors. So the bottom line is they ranked the research studies through their literature review, and they arrived at conclusions. And I want to present some of the conclusions to you that are related, I think, to brain injury. So if you were to look at this document, they would look at, there's a section in there entitled Health Topics and Prioritized Health Endpoints. What are the therapeutic effects of cannabinoids on these different health points? The ones that are in blue, I highlighted, I selected for this presentation to look at, the effect of cannabinoids on chronic pain, epilepsy, spasticity. Unfortunately, it's related to spinal cord and MS, not TBI. Another category they looked at was TBI itself. They looked at anxiety, depression, sleep, PTSD. So let's go right to the findings. The therapeutic effects for chronic pain. They found that there is substantial evidence that cannabis is an effective treatment for chronic pain. The bottom line is a key article was from 2015. It was entitled A Systematic Review and Meta-Analysis that was done by the Journal of Medical, JAMA, the Journal of American Medical Association. And it looked at specifically nabiximols outside of the US and so on. So the bottom line is they found good study and they were able to conclude substantial evidence. Unfortunately for epilepsy, there is insufficient evidence to support or refute the conclusion that cannabinoids are an effective treatment for epilepsy. What they said is that recent systematic reviews were unable to identify any randomized controlled trials evaluating the efficacy of cannabinoids for the treatment of epilepsy. Their findings were that the clinical data consists solely of uncontrolled case series which don't provide high quality evidence in efficacy. So that's pretty shocking. I thought that was a well-known finding. Spasticity, they said that there's substantial evidence that oral cannabinoids are an effective treatment for improving patient-reported multiple sclerosis spasticity symptoms, but limited evidence for an effect on clinician-measured spasticity. And they said that it's interesting that, folks said that they felt better. However, when using the modified Ashworth scale, that these same patients with MS could not be corroborated by the clinicians treating them. And then that there's insufficient evidence to support or refute the conclusion that cannabinoids are an effective treatment for spasticity in patients with paralysis and spinal cord injury. With regard to TBI, I'm going to move pretty quickly here, folks, because I'm afraid I'm running out of time. I have about 25 minutes left. So there's limited evidence of a statistical association between cannabinoids and better outcomes. And when they define outcomes in the studies, they look at mortality and disability. That after a traumatic brain injury or an intracranial hemorrhage, the bottom line, there's a small body of literature reporting the neuroprotective effects of cannabinoid analogs in preclinical studies of head injuries and observational studies in humans, article reported in 2016. So the bottom line is there's a suspicion that there is, if there's a positive test of cannabis use when a person is injured, there's better primary outcome scores as indicated on the modified Rankin scale rather. Also some evidence that's being described about CBD use or marijuana use in between concussions as a neuroprotection, but again, limited evidence. Going on to anxiety, limited evidence that cannabidiol is an effective treatment for improvement of anxiety symptoms as assessed by a public speaking test. Again, this is one of the suspicions that CBD would really help in the area of anxiety management. For depression, limited evidence that these two agents, nabiximols and dronabinol and nabilone, are ineffective treatments for the reduction of depression. So limited evidence. Sleep, some good evidence, moderate evidence that cannabinoids, and again, nabiximol is that agent that is used widely outside of the United States, but it's not FDA approved yet, as an effective treatment to improve short-term sleep disturbance. Then with regard to PTSD, there's limited evidence, just a single small fair quality trial, that nabilone, again, one of the agents, the early agents that were FDA approved, is effective for improving symptoms of PTSD. Okay, so this report also goes into the risk factors associated with marijuana use. The bottom line is, does it impact cancer? Does it give you a higher risk for respiratory disease? What about injury and death and so on? So again, I selected just two kind of broad categories, one entitled psychosocial, where the impact on cognition was discussed. And then the second one was mental health, where the impact on psychotic disorders and mood disorders like schizophrenia and bipolar were looked at. So let's look at those. Again, NASM in that report that was identified and published in 2017 looked at cognition, employment, and social functioning. What role does marijuana play or impact on cognition, employment, and social functioning? And unfortunately, there was moderate evidence, not a surprise to many of us, of a statistical association between acute cannabis use and impairment in cognitive domains of learning, memory, and attention. And so they looked at those three domains, learning, memory, and attention. They looked at it in relationship to a number of systematic reviews that have been done. There were 94 systematic reviews during the period of 2000 and 2016. 5 were considered good quality. And there was strong data from these 5 reviews that said there was an immediate impact of cannabis use on learning, memory, and attention, but that there was no data to support the sustained effects of cannabis use after cessation. So the bottom line is it does negatively impact cognition immediately after use. The rest of these you can read. I will skip over them just for the sake of time. But it talks about marijuana impact on academic achievement, unemployment, and being able to engage in appropriate social roles. So the risk factors associated with mental health, and specifically schizophrenia. The question is there an association between cannabis use and the development of schizophrenia or other psychoses? There is. They found a substantial level of evidence of a statistical association between cannabis use and the development of schizophrenia and other psychoses, the highest risk among the most frequent users. So, the bottom line is there were several good quality systematic reviews. Magnitude of association is moderate to large and appears to be dose dependent, may be moderated by genetic factors, but bottom line, there's a substantial evidence as indicated here. Is there an association between cannabis use and the course of symptoms of schizophrenia as opposed to developing it? How about impacting it? Moderate evidence that there is an association between history of cannabis use and better cognitive performance with folks with schizophrenia. That's interesting. Limited evidence of an association in increase in positive symptoms of schizophrenia like hallucination, displaying hallucinations, and moderate evidence for no association between cannabis and worsening of negative symptoms like blunted affect. With regard to mental health in the area of bipolar disorder, the question was, is there an association between cannabis use and the development of bipolar disorder or mania? And this indicates that there's limited evidence of an association between cannabis use and the likelihood of developing a bipolar disorder. So not so much in developing a bipolar disorder, but you go on to say, is there an association between cannabis use and course of symptoms of somebody that has a bipolar disorder? And it says that they found that there's a moderate level of evidence between regular cannabis use and increase in symptoms of mania and hypomania in individuals that were diagnosed with bipolar disorders. And I think that has tremendous impact on our populations, who many of them do have some level of mood disorder. So again, use of cannabis with regard to folks who have an existing bipolar disorder or mood disorder. Is there an association between cannabis use and the development of depressive disorders or symptoms? There's moderate evidence of a small increased risk for the development of depressive disorders, so it's important. Is there an association between cannabis use and the course of symptoms of depressive disorders? And there's no evidence to support that cannabis use and changes in course of symptoms of depressive disorders. From a standpoint of development of anxiety disorders, there's limited evidence of developing any type of anxiety disorder except social anxiety disorder. Moderate evidence of increased incidence of social anxiety disorder with regular use. And then this question of, is there an association between cannabis use and the course of symptoms of anxiety disorders? Limited evidence of a statistical association about use that's nearly daily in frequency and increased symptoms of anxiety. And then the last area that we'll talk about from this report is suicide. So the bottom line is there an association between cannabis use and suicidal ideation, suicide attempts, and suicide? And what they found is that there's moderate evidence of an association between cannabis use and increased incidence of suicidal ideation and suicide attempts, highest among heavy users. And moderate evidence of a statistical association between cannabis use and increased incidence of suicide completion, which is incredibly sobering to take a look at. So we reviewed a lot of things from this report. Like I said, it's a very dense report. You'll find it a wonderful resource that is available, easily available to you. Bottom line, in summary, chronic pain, substantial evidence, insufficient evidence with epilepsy, kind of mixed reviews on spasticity, limited evidence about protection against TBI, anxiety and depression, limited evidence. The risk factors, definitely moderate evidence for cognition, substantial for developing schizophrenia, moderate evidence that it could induce hypomania for folks that have a bipolar disorder, and then this very sobering information about suicidal ideation and suicide completion. So hopefully that information helps to inform you as a provider about kind of how we look at medical marijuana with regard to our populations. So let's shift now in the last 15 minutes from the clinical side of this discussion to the operational side. And let's talk about New Jersey's medical marijuana program, signed into law in 2010, operational 2012. People can become involved in the medical marijuana program if they are deemed to have a serious medical condition. They have to be approved by a physician, and now it's been broadened by some of the amendments to include nurse practitioners and physician's assistants. They have to be registered. Caregivers can be approved to deliver medical marijuana to patients, can pick it up at the dispensary and bring it to the patient without penalty. You have to get it from an approved marijuana dispensary. There are approved forms of medical marijuana that are available. Okay. So these are the serious medical conditions that have been deemed appropriate for New Jersey. The top 5 medical conditions, according to the website that I looked at, were pain due to musculoskeletal disorders, about 29%, anxiety at 23%, intractable skeletal spasticity 15%, PTSD 7.9%, and severe or chronic pain due to cancer 5.6%. So you think about all of these conditions and you think about what the 2017 report said about the impact of cannabis on these types of disorders. But this is what's available and this is what people get approved for. So you know, people have available to them medical marijuana. The question becomes, how do we incorporate medical marijuana into our practices? And our practices are institutional settings, from hospitals to acute rehabs to skilled nursing facilities, programs like mine that are post-acute residential, outpatient programs, and so on. And so let's take a look at how to potentially do that. And so, for me, I took a look at what the legal literature had to say about it. And so, here's just some ideas. There's nothing definitive here, but just ideas for your consideration. And according to this article that I read, that healthcare administrators must remember that medical marijuana, despite being legal in New Jersey, is still classified by the federal government as a Schedule I controlled substance. Laws vary from state to state. So hospitals and the healthcare associations that developed and implemented a wide range of policies addressing the use and possession of medical marijuana products. Policies range from strict prohibition to sanctioned self-therapy during hospital admissions. So they looked at some of the states that have been practicing for a while, like Washington and Minnesota. So again, looking at the New Jersey plan, medical marijuana enables qualified patients to designate up to 2 caregivers who are registered with the Department of Health to purchase, transport, and administer medical marijuana products. So somebody has to be designated a caregiver to administer. The person themselves can self-administer, or up to 2 people can administer this. Not our staff, unless our staff are designated as a caregiver. The REMED program that I work with will not permit a REMED staff member to become a designated caregiver. So that causes a dilemma. Therefore, hospitals and other residential facilities could permit a caregiver to possess and administer medical marijuana to the patient, then remove it from the premises. The Washington policy requires each patient to designate a provider who will bring the medical marijuana product into the facility, administer the medication, then remove the unused product. It states, the state of Washington Healthcare Association says that they will not assist the patient in obtaining or using medical marijuana, storing it, or ensuring that it's used properly. Staff involvement is really limited. It is simply confirming the patient's status as to who the medical marijuana user is, and the use of medical marijuana does not impact any other residents. Failure to follow the policy, facility reserves the right to enforce consequences, including discharge. And it goes on to say that the healthcare practitioner may only continue medical cannabis as the patient's home medication if the patient has their own supply, the condition warrants continuation, the reason for the admission is not due to adverse event from medical cannabis, the healthcare practitioner and designated hospital personnel are able to verify that the patient's currently enrolled in a formal registry program and got their supply from a licensed distributor, and that medical cannabis from states other than the state of current residence are considered contraband and should be dealt with the same policy for securing unauthorized drugs. Goes on to say that the healthcare provider will determine if medical cannabis is necessary to continue use while hospitalized and will authorize continuation of self-directed therapy. Questions or concerns should be directed back to the manufacturer's dispensary. Medical cannabis will be administered by the patient or a registered designated caregiver per labeled instructions. So again, the healthcare provider is out of it. Can't be left unsecured at any time. Medical cannabis can be stored securely in the patient's room if you as an agency are comfortable with that, or a designated area as defined by the hospital via some kind of a lockbox or safe or something like that. And that nurses and other healthcare professionals will not retrieve medical cannabis from storage or observe administration of the medical cannabis. So it's truly a very hands-off process, and even to the degree that the medical provider is not required to document it in the medical record. And then when a person's discharged, let me go back to that real quick, sorry. Upon discharge, the remaining medical cannabis will be removed by the patient or the designated caregiver. Provider of healthcare services is not obligated to address the ongoing use at the time of discharge, and to consider having the patient or registered designated caregiver sign some kind of a waiver indicating acceptance of full responsibility for storage and administration of their medical cannabis. So, interesting way of looking at it. If you feel comfortable as a provider allowing the patient to self-administer or having designated people come into your facility and allow them to administer with you, having kind of a hands-off level. So some further recommendations: consult your state agency, consult Department of Health and the DEA, obtain consent from the resident, POA, or guardian, consult your own legal counsel, review guidance from professional organizations, develop appropriate policies and procedures. REMED is in the process of doing that. Adopt appropriate guidelines, involve compliance and ethics programs, consult insurance carrier and brokers if that's indicated. And enrolling in list services means, taking a look at different websites that can provide you with ongoing dynamic information about this process. So, the final couple minutes of this presentation, let's talk about serving medical marijuana patients in your clinic or in your setting. This was an article that I found interesting. It was written by Allison Bell, January 2019 article, the OT Advance. And she was writing from Washington, D.C., where medical marijuana was legal, and so was recreational marijuana. And the bottom line is, what she is suggesting is that rehab practitioners should become fluent with education about medical cannabis, and to be able to talk about what the findings are, because many people are operating with limited information. And so to be able to discuss some of the findings that we presented today. Acknowledge that acute cannabis use, immediate use, impairs balance, it can impair cognition, and it can impact tone. And so to be aware of that includes evaluating for false risk, evaluating for impact on cognition, and so on. She goes on to say that clinicians should consider scheduling treatment outside of the acute use. When is their med administration time? Do they come into the clinic, a number of hours later when the acute psychoactive effects are less prevalent? To counsel medical cannabis users to avoid driving for 4 hours after inhalation and 6 hours after ingestion. Development of activity patterns that account for medication schedules, working around those acute intoxication events. That because cannabis can increase blood pressure and heart rate, advise users to monitor their vital signs during exercise. To counsel patients about possible risk for return to work and having positive drug screens. And then counseling patients at qualification for certain federally funded things like housing is subject to federal laws. Applicants could be disqualified for marijuana use. It's a real catch-22 situation out there. So these are kind of practical, and there's certainly a lot more that we can develop over time and share among each of us as providers. This was an interesting article on medical marijuana in the Journal of Neurology in 2014. And this particular author wrote that medical marijuana should be available for most refractory patients, for those who have serious symptoms that have not responded to other treatment. Until we have more and better data that medical marijuana should be considered after more standard and proven treatments have been exhausted. And that medical marijuana should not be offered out of order to patients who are not compliant or want to bypass the standard treatments. I thought that was kind of pretty interesting to say, yeah, let's consider it, but let's not exclude the things that we do know that have a tendency more to work before we go right to medical marijuana. So here's the conclusions. So where are we now? Well, we know that we're advancing approval for medical and recreational marijuana. State of New Jersey is maybe right on the threshold of legalizing recreational marijuana. We know that there's continued limitations in the research to confirm use efficacy, effective dosing, and subsequent distribution methods. So again, this idea, we seem to say that there's there's enough evidence for effective treatment for chronic pain, effective treatment for some spasticity, that there's a positive impact on sleep. We know that there's definitely a negative impact on cognition, increased risk of advancing schizophrenia and psychoses, can increase symptoms of mania, small increase in the development of depressive disorders, and increased incidence of suicidal ideation. So there's limitations in the research, but there are some findings that we can begin to kind of rely upon, it seems. And there's a challenge of incorporating medical marijuana into the treatment plans with current state and federal guidelines. The part of this that we just talked about. So where are we heading? Decriminalization of marijuana, with further steps towards legalization at the state and federal level. I don't know where it's going to go from a federal perspective. I understand, just read something that Joe Biden's not a fan of legalizing marijuana, so we'll see where that goes. Changing marijuana from a Schedule I drug to a Schedule II or III so that research can be done. Would love to see that happen. That's been on the books for a while to try to make that occur. And formalization of marijuana as a medication that is FDA approved and can be dispensed by pharmacies as prescribed by physicians. And that we see that it can be covered under health insurance. Right now, majority of people are paying for medical marijuana out of pocket, and it gets expensive. So just in summary, my belief, I still don't like the negative impact on cognition and risk of mood disorders for medical marijuana that is higher in THC. I'm very open to the use of CBD, but not as a primary agent. I'd like to try other tried and true approaches and use CBD as an adjunct. But I definitely want to see marijuana legalized and reclassified so it can be studied and monitored more closely. Always open to see something that's going to help survivors of brain injury. I thank you for your time and attention, and stay safe out there.